صباح الخير. شكرا يا دكتور شريف for introducing me. وانا بشكر يعني الحضور in this very important topic. انا شايف ان دكتور ماهر بيه قاعد معانا في السيشن، فدايما لما بلاقي دكتور ماهر قبل ما اتكلم I become particularly attentive. اوكي، حضراتكم سمعتوا الدكتور محمد يونس كان بيتكلم معاكم about الباثولوجي والباثولوجيكال اناتومي. You've heard about how we reconstruct acetabular deficiencies. فاحنا هنتكلم على few cases. فبasically this is a case of mild dysplasia. Okay, she's a lady who's actually the wife of an anesthetist. She presented at the age of 51, 52. Okay. What do you want to do for that lady? Well, she has pain. She has pain in the groin, in the left groin. She's presenting with pain. She's a very active lady. تركب خيل وبتاع وحاجات كده. فهي she has pain. Do you think this is a dysplastic case or a non-dysplastic case? Sorry? So there is a bit of dysplasia. Actually, when I show you the whole pelvic views and you see at the angles, you will probably realize there is a case of dysplasia. So this is a patient with an arthritic hip. It's a secondary arthritis for dysplasia. She has a mild dysplasia, so the mechanics are not ideal for a long functioning hip. So she's presenting with pain. What do you want to do for her? Total hip, right? احنا دلوقتي في كورس بتاع total hip replacements, ف we want to do a total hip replacement. Do you expect any difficulties in doing this hip? There's a bit of a shallow acetabulum. Does this mean that you will have a problem when you do this hip? You might find some difficulties in implanting your cup? Do you need a CT for that? Okay. Right, so you want the depth to be stable. So one of the first things you think about is the deficiencies you might face for a case of dysplasia. Right. Who thinks they will have a difficulty in doing this case in terms of acetabular reconstruction? Well, I don't think anybody is expecting a lot of difficulty. Basically, I've replaced her other hip about a year before, and now she's presenting to get her left hip replaced. There was no issues. It was a straightforward primary. The depth is okay. You might argue that maybe here there's a bit of uncoverage, but in fact, the anatomy here is not that much distorted. We've heard these 4 pillars. I think Dr. Yunus اتكلم عليهم قبل كده. I always keep on repeating them. To me, to my very simple understanding, you need 4 mechanical pillars for a successful THA. You need to put your cup at the center of rotation. And when you put your cup at the center of rotation, you have to deal with the bone stock you have. In a dysplastic case, contrary to what people expect, the best bone stock is where the center of rotation is. Even if this is the site which has never been occupied by femoral head, بمعنى إنه your cup did not develop fully, the acetabulum did not develop fully, still this is the best bone stock. It's the best bone stock anterior to posterior. If you go higher up, you might have a better bone stock mediolateral, but not that much as well. For the best bone stock is at the center of rotation. And you need a best bone stock if you're going to implant any kind of a cup. So you need center of rotation with an initial cup stability dealing with the bone stock. And then the last factor is the femoral reconstruction. حضرتك تقدر تلعب بالoffset, and playing with your offset will affect 2 things. It will affect your leg length discrepancy, and it will affect your abductor lever arm, and that will affect your function. Okay? These are the 4 simple principles. They are my goals, they are my objectives. If you do a hip within that condition, first the corners D, provided you have a good soft tissue, your hip should be okay. Your patient should function well. But that's what we've done. So it's a reproducible thing. So it isn't an issue. But dysplasias are not always the same thing. Okay, so we have cases like this, we have cases like that, we have cases that look like this, and we have cases that look like this. Okay? But we have different categories of dysplastic hips. They are different grades. We know the classification. I'm not going to talk about the classification. So we have dysplasia starting from deformities and deficiencies at the level of an acetabulum and the proximal femur at where the hip should be, يعني في center of rotation. حاجات كده بتبقى شكلها عاملة زي كده. يعني هنا اهو أو عاملة زي كده. When the hip gets more and more dysplastic and it goes up, then you start to have other things until the hip gets dislocated completely and it has never occupied the acetabulum. Okay. This is exactly what you should not do. This is it's a nice case. So this is a lady who's presenting and هنتكلم عليها في الآخر. She has already had that hip done. It was an attempted high hip center. This is where you're supposed to put your cup. Let's proceed. So this is another case. Okay. What are the difficulties you're going to face in here? Okay, there is a distortion in the proximal femur. Yes? طرحك. So there's a bit of an acetabular dysplasia. If you follow the angles from here to there, yes, this is a vertical cup. For sure, there's a dysplasia. Okay, not significant, but there is a dysplasia. What else on the soft tissue side? There's a bit of an upward migration. There is an overgrown of the greater trochanter. And the medulla is a bit distorted. There is always a pathological anatomy on the femoral side. People think dysplasia is about the cup. The dysplasia is on the femoral side as well. You will also realize that this lady has a lot of internal rotation range. Okay, يعني رجلها عامله كده. وهي الحكايه دي دايما بنلاقيها في الديسبلاستيك hips. When you go inside you find the lesser trochanter is way posteromedial. وبالتالي لحضراتكم اللي بيعملوا ال version assessment in relation to the lesser trochanter, you'll be in trouble because you will put your hip in too much internal rotation. What about the soft tissues? Yes. Iliosong, the capsule. Okay. Is the capsule short in dysplastic cases? They're not. They're usually not very short. There's two parts of the capsule. في part بتبقى لازقه كده فوق الاسيتابولم بتحتاج تعمل لها شويه ريليس واول ما بتعمل لها ريليس the capsule is not really that short. طيب, what do you want to do for that? Total hip, yes. What kind of total hip? Do you need special devices, special stems, special cups? Small cup? Do you need a small cup? Okay. Or what if you don't want a small cup? What dictates the size of your cup? The bone stock. But what part of the bone stock dictates the size of your cup? The anterior to posterior diameter. So it's not about the superior deficiencies, it's about the anterior to the posterior diameters. Okay, to cut a long story short, this is what we've done. In the young age population, I tend to like to do cementless reconstruction on the acetabular side, not because the cementless cups do better, but because I don't have a highly cross-linked poly. I will disagree with Mr. Halawa about that, but I prefer to use kind of a more harder weight-bearing surface, either highly cross-linked poly or a ceramic. So this is why I choose this, but you can do something else. And I'm going to show you different techniques. But this is what we've done for this young man. Now, yes, we put a bone graft and reconstruction from the femoral head. From the very small femoral head, we had enough bone to put that. I can show you the pre. So you have, this is a very nice piece of bone. Okay? So that was on a flyover technique with 2 screws. Nowadays, I use a different technique, but that's what I was doing. This was probably done about maybe 12 or 14 years ago. The high riding GT, the high riding greater trochanter. But there's no impingement because remember that greater trochanter is looking backwards. Okay? But you can do fairly amount of abduction. I think there is a very hypoplastic lesser. The lesser is very, very small and very hypoplastic, and it looks posterior. Okay? Right. What about that? Okay, so this is basically another dysplastic case. Okay, so we can see the very highly dysplastic case there. The deformity is present. Okay. So what would you like to do? Sami, what do you think? Yes, okay. كلنا هنعمل هنا total hips يا جماعة للdysplastic cases. Okay, so that's the introduction. What type of a hip? First of all, always ask yourself the questions. ايه البروبلمز اللي هتقابلني؟ Divide them, acetabular side, femoral side. Do you think there's going to be a problem with the femoral side? The acetabulum side is more. Yes. So المشكلة هتبقى فين؟ So how do you know the deficiencies? So you can see this is the teardrop, right? This is the anterior wall. If you have a look here, there's an anterior wall, and the posterior wall is behind. So that's posterior wall, and that's anterior wall. Okay. So do you think the anterior to posterior diameter here is reduced or not reduced? Do you think you're going to need a small cup for that? Definitely not. This is, with a subluxed hip like this that's mushroom, the anterior to posterior diameter is going to be quite large. Okay? So what's the problem if you're going to have a large anterior to posterior diameter? You will probably have a bigger superior defect, right? Because you have to put a large cup. Right. Are you going to have a problem with the shortening and the leg length and stuff like that? Well, this is where the femoral head is, but this piece of overgrown bone, probably, if you put your cup here, you can probably use a good amount of bone stock for any kind of reconstruction you want. What would you like to do? What type of reconstruction? First of all, on the cup side, cemented, cementless? Cementless. Who wants to do cemented? I might want to do cemented. I don't have anything against it. So if you do cemented, how are you going to reconstruct that? What is the technique? What are the options? There are different options, by the way. You can either reconstruct the way you want, but tell me what is the option. Okay. Do you want the special revision cups? Okay. Right. So you can do impaction grafting. You can do a bulk autograft if you want. You can use a cemented or a cementless. It depends on what you want. You can use an augment. Some people now use augments. There are different ways. Depends on your technique. The best technique you know, and the best technique that gives you the results. In our case, what we've done is this. So basically, we've taken the femoral head. There was an abundant amount of bone. We've put these screws above. We put a cementless cup and that. And I think this lady was done something like maybe 14, 15 years ago. Okay, and I think she's done well. Right. Then we can have something that's even more. So we have a dislocated hip. What are the problems you're facing here? There's definitely a limb length discrepancy. What else? So we have really a high dislocation. So the soft tissue is going to have a problem. Do you know where the iliopsoas is? The iliopsoas is going from here, like this and like that. Okay? And that's where the capsule is. So this is where the hourglass contraction happens. What about the socket? It's a very shallow socket. What else you might find in that socket? It has a small diameter. It is a small socket. Will you find the socket? Sorry? It is difficult to find. It's true. It is going to be difficult to find. But do you have any tricks to help you to find it? Ligamentum teres. Okay. Ligamentum teres, maybe. Image is an easy thing to do. This is one technique. What else? The transverse acetabular ligament, if you can find it. Will you see walls in these cases? Will you find a wall, like an anterior and a posterior wall? They usually look like a saddle, okay? When you go inside in these empty sockets, you find it like a saddle. فبيبقى عند anterior and posterior wall are they're not protruding, but they have a decent length. But they don't look like it because there's too much bone which is filling this area. فهتلاقي ان الحته دي مقفوله وفي بون كتير هنا وفي حته كده زي الريدج كده طالعه anterior and posterior. Something very, very important as well. What is the quality of the bone? It is very, very soft. Very soft. Beware. If you ream into it زي ما بتعملوا أي hip عادية, it's contrary to when you do the previous case. Here, the bone was quite hard because this is bone that has been subjected to stresses. But here the bone is very, very soft. So you have to realize that. Okay. طب يبقى عند حضرتك المشكلة إنه الcup is very small أو acetabulum is very small. It's soft. The walls are not very, very obvious. But one trick how to find it, you follow the sciatic and the iliopsoas. You'll find that the sciatic and the iliopsoas, they look like that. And in between is going to be your acetabulum. For the sciatic will be covering this area that looks like an ischial tuberosity, which is not really an ischial tuberosity. It is not really very prominent, although here you can find it. عشان توصل لده. وبعدين, how do you identify the depth? A little technical trick that I tend to use. I drill, okay? So take a small drill and drill that area. So I just simply drill it. And when you drill it, it gives you an idea about the depth. Sorry? You can't feel the depth because you're not going to put your finger in the obturator foramen, but you simply drill it, and then when you drill it, you measure the depth. فيتلاقي إن في مثلا 3 سم 4 سم and so on. Okay? So basically, what type of reconstruction you want? Cementless, cemented? Cementless, okay. Cemented? Cemented cup? Will you need some reconstruction for that? Graft? Okay. Actually, this lady was done many, many years ago. She's coming from Yemen. And in fact, will you have a problem when you put your cup here to bring down this femoral head down? في مشكلة ولا ما فيش مشكلة؟ في مشكلة. إيه المشكلة؟ Soft tissue and sciatic. Okay, beware. If you lengthen more than 3.5 to 4 centimeters, you have a risk of a sciatic palsy. Okay. Is there a test that you can use intraoperatively to assess your sciatic? It hasn't been, nobody said it clearly, but what I tend to do is I feel the sciatic and I can feel the tension, and I feel it when the knee is bent, and when you extend the knee, you find that the sciatic is getting so much tighter, there's a problem. Okay? Right, so basically, this is the technique I used, which is basically the Sponseller-McBeath technique of shortening osteotomy. So we did the osteotomy. I did a cemented reconstruction with a mesh and bone graft. This is a technique which I learned from Dr. Maher many, many years ago. I still cherish that technique. It works. It works. I haven't revised so far for an aseptic condition any single person. Maybe some other people revised my cases, but I personally, I have not revised so far any single impaction grafted cases which I've done since I've returned home من 20 سنة. The first case I'm about to revise now for impaction grafting works. It works very well. والعيانة دي من أكتر من 8-9 سنين. She sent me this follow-up, which was then a 9-year follow-up. So you can see that the cemented reconstruction works. It works beautifully. That was standard poly, 28 millimeter heads. Okay, they do work. If you do them with meticulous technique, they work. Now, what about that? البنت دي الست دي عمرها 36 سنة. The story is that she's had problems with her hips now. Yes, I did shorten the femur, okay, and basically I used a 6-hole narrow DCP. The technique is that I put the rasp into the proximal part. I rasp before doing the osteotomy. So I prepare the femur before doing the osteotomy. وبعدين بعمل subtrochanteric shortening, subtrochanteric osteotomy. I put back again the rasp where it was. Then I pull on the leg. واخلي الاثنين يطلعوا على بعض. واشوف how much there is an overriding of the femur and I take away the part of the femur. في اتوصف techniques انك تعمل step osteotomies and so on for stability. I don't do that. I simply do it like this. ما بيبقاش. اوكي. خلوا بالك ان برضه بي عندك بروبلم ثانيه في العينين دول غير اللاج discrepancy هي البلفيك تيلت. الحاجات اللي دايما بتضايق انك لما بي عندك a long standing pelvic tilt for whatever reasons usually it doesn't get corrected very easily. العينين بي عندهم مشكله في انهم correct their pelvic tilt وكتير يبقى بيبتدوا بشورتنينج they end up with more length with a longer limb. اوكي سو نرجع تاني للست بتاعتنا. هي جايه من بورسعيد وكان عندها الهيب دي والهيب دي والقصه انها on the left hand side she's had that hip done 4 years before. فعملت هيب على الناحيه الشمال وبعد ما عملت الهيب على الناحيه الشمال الهيب دي اتخلعت ورجعوها تاني وبعدين ابتدت تمشي شويه قالوا لها خليكي في السرير 3 اشهر وبعد 3 اشهر قوموها تمشي تاني ولما قامت تمشي تاني راحت اتخلعت تاني. فلما اتخلعت تاني دخلوها تاني وبعدين حطوها في سبايكا و she stayed in a hip spica for about probably couple of months وبعدين قوموها تمشي وما خلعتش. وبقت ماشيه عليها وبتقول لي it's painful لكن she's been working on it for about almost 4 years. First of all, you think this cup is stable or unstable? حصل فيه osteointegration في الحته الفوقانيه دي مش كده؟ That's what it looks on the X-ray at least. طيب. What about that one? Okay, so this is a dislocated hip. It's a crowd type 3 to 4, more or less 3. وعندنا false acetabulum هنا وعندنا another true acetabulum هنا. First of all, do you want to operate on her? أني ناحية. That's was going to be my next question بس دايما دكتور أبو سعود سابقني في التفكير. فمين عايز يعمل الناحية اليمين الأول؟ كله عايز يعمل الناحية الشمال الأول؟ Why؟ عشان فالتانية هيحصل فيها مشكلة. اوكي. طب ولما هي تقول لك انا دي اليمين بتوجعني اكتر من الشمال هنعمل يمين. اوكي. انا بحب اسمع كلام العيانين ان هم لما بيشتكوا بعدين العيانين هم اللي بيدفعوا الفلوس فدي حاجه كويسه. ف anyway so what is the problem؟ ايه الحاجات اللي هتقابلنا as a problem in this case؟ Soft tissue, yes, you're going to have a soft tissue. So do you think that on the right hand side you might need to do something for the soft tissue? Releases, yes. Shortening osteotomy? 2 minutes, okay. You want to do 2 minutes? Okay. Right. That's basically the pathology. When you look, you can see that this is the false acetabulum. The true acetabulum, this is the false acetabulum. And if you look from the contralateral side, this is what your acetabulum looks like. Do you think you will need a normal cup or you need some grafting and reconstruction for that? Who thinks you need grafting? Okay. Who thinks you can put a normal cup here? Okay. Good. So this is what it is. This is your false acetabulum. When you go inside, you have to look for these. These are where the true centers of rotation are. And the nice thing about it, when you study the axial cut will give you a good idea about what type of nice bone stock you have. This is a nice bone stock. These are the very small anterior and posterior walls. So this is what we've done for her. فاحنا عملنا التكنيك العادي. This is a cemented stem and it's a cementless normal cup. Okay, it's a 46 millimeter cup. We took a normal cup. Why cemented stem? Because it's easier for me when I do the at that time when I do the shortening osteotomy. It just fill it and you do good cementing and it works. أنا ما عنديش مشكلة من cemented stems by the way. I will ask you the question in reverse. Why cementless stem? I have some restrictions about the cemented acetabuli, but I don't have a problem with the cemented stems. They do as good, if not better, than cementless. Well, it didn't. It has never done. Now? Yes, it is dorsal, but you can argue and say I could use a cementless stem on that as well. This is an argument, but it's your choice. طيب ايه اللي حصل بعد كده؟ لما انا جيت قلت لها طب يلا هنعمل الناحيه الثانيه وابتدت تمشي، مشيت اول شهر وبعدين سمعت كلام عبد المنعم وراحت خلعت. فناو we have to do the other side. To cut a long story short because of the time, أنا بخاف من أبو سعود لما يبتدي يقول لي فاضل لك دقيقتين. This is what we've done. Do you think that this cup is covered here or not covered? يعني do you think there is an empty هل المسمار ده أنا حطيته كان في الهواء كده وأنا مبسوط منه؟ No, actually there is. You can see this is the bone stock that we have there, okay? This is the anterior, the most anterior part where the previous cup was. أنا عايز أوري حضراتكم حاجة بس قبل ما نخلص. بصوا الكاب ده لما خلعت حصل فيه إيه؟ Look at the cup here. اتعدل. Which means this cup was loose. It was not integrated. هي كانت ماشية عليه كده ماشية غريبة. لكن anyway, this is basically a close-up view عشان تشوفوا this is the bone stock that is covering that cup. This is a standard cup. We didn't need any bone grafting, the same because the other size is good. No? لا قول تاني حضرتك. Yes, I know. أنا بقول this is some people get confused إن إيه الوايت لاين ده فيبقى الكاب ده is uncovered. It's not. This is the white line which is anterior in the ilium. فاهم حضرتك؟ لكن الدوم is fine. وبالتالي this is what we had before. Oops, there is a problem here. كان المفروض الصورة دي تبقى قدام الصورة دي. فكنت هوري حضراتكم التو hips لكن I think in the two hips will look here. Okay? And she's done well. Dysplastic cases, there are challenging cases that require special preparations. You have to do a proper CT preoperatively, good planning, decide what you need. Most of the time you can use standard hips. You don't need special devices or very expensive cups ولا CAD cam ولا حاجات كده. Most of the time you don't need an augment. It doesn't matter what technique you use. Both techniques work well if you use a cemented reconstruction with a graft, whether impaction or none. It depends on the technique you like. The impaction grafting works. أنا وريت حضراتكم حالة أعتقد إن هي probably عاشت أكتر من 15-16 سنة. أنا followed I lost her for follow-up. With cementless techniques they also work. The key is to do your technique well. Thank you.